Okay, sir, we're live.
You're live, right? Okay. So, a very good evening to all the participants to this session. So, we'll be discussing about CT head and C spine mainly, and some like the objective of this topic is mainly to like explore the packs and other things so that we'll be comfortable while scrolling and also recognize the patterns. Okay. So welcome Arushi, Ankur, Vaishnavi, Mayuri, and all of the. And also, I would like to thank Mehul for organizing this session. Okay, and if you are having any doubt, you can ask at any point of time. Okay, just in the chat or in directly you can speak. Okay, it's okay. Okay, so we'll start with the CT head. Okay, then yeah, can you see this? Yes.
Yes, sir, we can see.
Okay, you can see. Okay, Mayuri, describe this. Mayuri? Yeah, you can.
Me also.
Okay, Mayuri. Okay, or Sobik.
Hello.
Yeah. Any one of you just you can see this one, right?
Yes, sir.
Okay.
This is NCCT Head
Uh-huh.
showing some hypo.
Some okay, multiple there are multiple things over here. Okay.
Yes.
So this is what just a picture, right?
Yes, sir.
This is a picture for you. There is a visualization and this is a picture for you. Okay.
Yes.
So in this one, there are multiple things here. Even though like you can see this part describe. Okay. This is also a pattern here. Okay. This is only a letters. Hana? These are letters. You can see my mouse right here. When I'm
Yes.
yeah. So when I'm doing this you can see this. So you are able to identify D, E, S. You can identify the letters. So this is also a pattern which we have learned from like so. And now you are seeing a picture here, which is also showing something which we have to recognize. Okay. So this is also information, visual information. That's it. Okay. So similarly, so when you have this sort of information which is almost clubbed together, so like seeing is believing bolte na. So similarly, like usually when we see something, like there can be information in that one as well. So similarly, so see this one. So what is this? Anyone can speak, not just Sobik or anyone. Like this is an interactive session. I want this to be an interactive session so that you will learn a lot. Okay. So anyone can interact at their own will voluntarily. Okay. So this is what is this?
Food thali.
Okay. Thali. Again, you have this one. Can you eat everything at a time?
No, sir.
At a single point of time, if you order something thali, so you can't eat everything. So you require organization, structure to have anything. Okay. So this is, even though this is a Bahubali Thali, you can't take everything together. Okay. You require in an installment, you will require a structure so that the thali is organized in a way so that you will eat one at a time. Okay. So we'll organize it in like in dine-in, what we'll do, there will be starters, then we'll eat mains, then desserts, then extras. So this is how we go, right? So usually, so for a thali, you are doing this, and for a CT scan also, there are some structures. Okay. So this is what I want to emphasize. So these are the mental models which we develop so that we identify some difficult things so that we won't, and we follow a systematic protocol so that we don't miss anything, right? So there are some mental models for this one as well. So we will be discussing those as well today. So like coming to the so today we will be discussing about the CT, right? CT head. As we all know, CT is what? X-ray, multiple X-rays, and it is already like like multi X-rays, and there are you can see this is a gantry, and as the patient goes through the gantry, then there is a multiple X-rays beam shooted upon the patient's body. Then it will be rotating. There will be spiral like helical this one. So at very speed, like at a high speed, the patient will have like X-ray will be taken at many sections. So and this will be analyzed by a computer. So this is a CT, computer tomography. Okay. So we will analyze the sections, and there are multiple terms as well, which we'll learn through this in this session as well. Okay. So the basic concepts. So you are seeing what? you are seeing your eye can see 7 colors visible in a visible spectrum. But the X-ray or the CT scan eye is mainly regarding, it can see only black and white, and there are a lot of shades of gray. So this is a world of black and white with shades of lots of shades of gray. And our eye can only distinguish between one gray to another gray, one shade of gray to another shade of gray. So that's why there are some important terms which we have introduced into this world. Okay, this is a CT world. So we call this one as attenuation. Okay, so this is called, what is this? Hyperdense, and this is hypodense. Okay, can you see this part of my screen? The left part or the right part? Hypodense or hyperdense?
Yes, sir. It's visible.
Oh, okay, it is visible, right? Okay. So this is the denser part. So this bone is what? This bone is denser. So we call it at higher attenuation because it is blocking all the X-rays or projected upon it. And this is called as hyperdense. And similarly, you can see this is, what is this? This is CSF. So this is less dense, and we call it less attenuation or hypodense or darken image. So, and this one, like when there is a presence of any abnormality or pathology, then it will call it as hyperdense like lesion or hyperdense thing inside a CSF or anything. Based on that, we will come to a differential later on. So we call it hyperattenuation or hyperattenuation based on this. Okay. So so in the black and white spectrum, we have lots of shades of gray here. So here we have what? And in English, air is called air, AIR. In CT language, it is denoted as a Hounsfield unit. Okay, so Hounsfield unit, -1000 is the air, 0 is water, and rest we have like CSF is at 0 to 10. Then white matter is what? It is with fat with some water. So it is somewhat denser, but not purely fat, right? So it is somewhat mixed with some tissues as well. So it is 22 to 30. Then gray matter is 35 to 45. So if you want to speak, if you tell me gray matter in English, CT will understand it in terms of 35 to 45 Hounsfield unit. That is its own language. So we have to understand the language of this one as well. So, and this is, blood is 55 to 75, and calcium is like 200 to 1000, and metal is 1000 plus. Okay, so this is the Hounsfield unit. As you can see, so this is the bone. Hounsfield unit is 1000. White matter is around +20 to 30. Then muscle will be around +20 to 40. Gray matter is this much. So here you can see there is intracerebral bleed, and this is the accounts to around like 65 to 75. Okay, so that is one thing. Okay, now you can see this screen, right?
Yes, sir.
Okay, you can see this while I'm scrolling this. You can see, right? Yes.
Yes, sir.
Mehul, okay.
Yes, sir.
Okay. Okay. So now you can see, focus on the top, bottom right part of the screen now. What are you seeing there? There is zoom, there is WW, and there is WL, right? So you can see that part, right? WW and WL.
Yes,
Yes,
yes.
sir.
Okay. So now here we come to, there is something called as, there is a term known as windowing. Okay. There are multiple windows. There are like window at a high level, window at a low level. So we need to know these terms so that we navigate through these, pictures. These are images stacked together. Okay. So now you can see here, you can see there, you have heard about the terms regarding the bone window, brain window, and other various aspects, right? So window, there is a WW and WL. WW is window width. You can see window width is 150 and window level is 35. Okay. So what does it mean? So window width is the range, window level is the midpoint. So if I change this, as you can see, I'll change can you see this, right? So I'll change this part to the bone window. Bone window is what? Hard tissue, right? So hard tissue will be what? Higher attenuation. So if I change this, you can see the window width and window level will change. Now you can see window level is around 300 and window width is around 1500. So what does it mean? Window level is the midpoint, 300, and 1500 by 2 is how much? 750. So 300 plus 750, 300 minus 750, and 300 is the midpoint of this attenuation. And I can do this part. I can adjust the window. You can see window level and window width are changing while I'm doing this. So this is how we can adjust our brains or our eyes to see the pathology. This is important. This is important because see here. Okay, so windowing, you can see this 40 is the window level and 0 to 80 is the window width. Okay, so if you don't adjust it properly, what will happen is, see, you can see this part windowing. Here you can see there is a bone over here, and this is the bone window. Okay, where you can only appreciate the bone part of the brain. And here is a soft tissue window. You can say, what is this? What are you seeing here? Large, there is a convexity. This is suggestive of, and it is lenticular shape. So this is what? SDH. So here in bone window, I can't see that. Okay. In brain window, I'm able to see. And you can see there is a mass effect as well. So adjusting a window appropriately is required to see the structures. Okay. So this is important. Okay. So, and while I'm scrolling this, you can see you can't see anything now. This is in the bone window, and you can see the window level as well, 851. Now I'll adjust it. There are already if I adjusted windows as well. So there are stroke window, lung window, liver window. Already there are presets available in all the packs. Okay, so based on that, you can just adjust it. So this is a brain window. Okay, so now coming to that, like we have known about, we learned about the window level, window width, and attenuations and various aspects. So now we'll go through the some part of it. Okay, so knowing the terms is one thing, and there is a skill part and there is a practice. Okay, so knowledge is one thing. We know that we have learned about the CT scan, right, in our MBBS and other days as well, but we did not practice. We did not put the knowledge into practice. So the skill will be almost will be vestigial in our this one. And when we identify the patient, when we look at the CT scan, we won't be easily appreciating details of this. So practice is also required, and there are some free sources available. Looking through these packs and other things. I will be later on discussing that. Okay, so now so the skill part is the scrolling, and also making sure to focus on one aspect of it, and our peripheral vision should see the other things. So like continuously we need to go through these images so that we'll get accustomed to the normal one and also identify abnormal one. Okay, so we'll first of all, so the mental model which I'm going to give you today is, okay, this right, any blood can be very bad. Okay, any blood can be very bad. Okay, so this is the mental model, and the first letters of the sentence which I've given, that is the thing which we'll be going through. Okay, so now any blood can be very bad. So A for airway. So air is what? Air is having a low attenuation or high attenuation. It is at what level? Obviously it will be -1000. So here, like while I'll scroll this, you can see here. Okay, so this is in a bone window. Can you appreciate here? This part is looking what? Black, jet black. Okay, and it is almost equal to this part. So it is almost equal to this part, right? So this is the air. Okay, so and we also should know this which part is which. So we are looking we are looking at the patient from foot end. Okay, so this part will be the right side of the patient, and this will be the left side. Okay, so this is the right side and this is the left side. So while we are scrolling this, there's a convention. By convention, we can invert it as well. But so the usual convention is this one. So so any blood can be very bad or blood can be very bad. All right. This is also a mnemonic you can use. So these two mnemonics you can use and mental models for that. Okay. So A for airway. Airway. I'm hearing a lot of noise. Hello. Okay. So in air, we look at what? Nasal and paranasal sinuses. Okay, nasal part is this part, and paranasal sinuses are maxillary. Then while we scroll up, then we find ethmoid. Then we have sphenoid over here. Then we have anteriorly we have frontal. Okay, so this is one thing, and posteriorly we have mastoid. Okay, so A for airway. So if the patient comes in, a trauma patient or any other patient with a epistaxis, so the usual differential in a nasal bleed will be what? what we think is, first of all, there might be an intracranial bleed, so seeping down through the nose. That is the first most important differential, and that is the can be life threatening as well. So the other differential could be what, any nasal bone fracture or any other things, right? So one thing is that, like, while we do this scrolling, so we can see for any bony abnormalities as well, like if at all, if there are present in these air. So if there are any hyperdensities or hyper attenuation, okay, high attenuation, then we we need to suspect some trauma to the maxilla, paranasal sinus or nasal sinus, nasal part, and with like bleeding. So there can be a hemosinus. This we call as hemosinus. So that is A part. A for any blood can be very bad. So A for airway. Okay, airway. So anterior part and posterior part. If the patient has any bleeding from the ear, so we need to look for any hemomastoidium. Okay, so this part should be appreciated as well. So here also we will find some hyperdensity. Okay, so that is A. Now comes any blood can be very bad. Okay, so B, A for airway. So the attenuation here is at what, so this is a bone window where we can easily appreciate this part. If I change this CT scan to brain window, now you can see there is a lot of information here. So when there is a lot of information available, then we'll get lost. So that's why we need to we focus. Okay, so here now blood is a soft tissue, right? So soft tissue can be easily appreciated in brain window. So we have changed it to the preset to the brain window. So now you can see some brain part. Okay, now as this is a soft tissue. So as you all know, there is a Monro-Kelly doctrine, right? So what is Monro-Kelly doctrine? I'll ask. Okay, Mayuri or anyone, Ankur or Avi Gambar, anyone? What is Monro-Kelly doctrine? Okay, so
Sir, according, sir, basically the Monro-Kelly doctrine says that the brain is a compact space. So it is filled by brain parenchyma, blood, and the CSF. So
yes.
if basically any one of them is increasing, it can accommodate till one point of time, after which the brain will start herniating off because of
Yes.
increased pressure.
Okay, thank you, Sobik. So this is a closed space, right? So this is a closed space, and in a trauma patient or any non-trauma or hemorrhagic bleed patient, usually these patients won't die of hemorrhagic shock because the cavity is closed. Okay, so there is accumulation of blood in the brain, but it will cause neurogenic shock if there is a brainstem involvement, but it won't cause hemorrhagic shock as such, because there is no, like, it can't even accommodate a liter of blood, right? So it won't even cause a hemorrhagic grade 2 as well. So the patient will die of the other causes, but rather than a hemorrhagic shock. So it is almost a compact space. When there is a accumulation of blood, the patient will the brain has to herniate because there is no other space left to for the brain to expand. So there are some potential spaces here available, and you can see here. So blood can accumulate where? Near some potential spaces. So you can't see epidural space here. It is a potential space. When there is a breakage, or like when there is a tear of blood vessels, there can be accumulation of blood in the epidural space. That is a potential space. It can expand later on. And similarly, there are some other spaces which you can see here. Some structures are there, black and white, and some shades of gray are available. I'll discuss that. So the blood. So what are the usual things which we see? Which we see? So usually epidural, subdural, and other things, right? So I'll discuss the other part as well. The artifacts and the thing. I'm just narrating you this one. So any air spaces. So maxillary sinus, frontal. These are the frontal sinuses. So these are the spaces. So if there is opacification, we need to look at what? Any fracture until proven otherwise. And in non-trauma patient, we look at any infection, tumor invasion, or any inflammation. Okay, so you can see here in this was a trauma patient, and you can see there is a loss of continuity of the cortex of anterior part of the maxillary on the right side. So this is a right side. So we'll look at the patient from the foot end. So this will be a right side. So this is a right side with what you can see here. Usually we will compare it with other side, because On the left side, it is normal. So you can see there is black color and jet black. So this is suggestive of air. Here you can see air is there, but there is also some structure is filling that cavity. And so there are multiple bone fractures of maxillary sinus with hemosinus as well. So this is what, and similarly, there is a hemosinus in the frontal bone as well. Okay, so next part is the brain. So brain can accumulate where? It can be extra axial or intra-axial. Axial is the term we use. Okay, so extra axial is outside the brain. So it can accumulate outside the brain in terms of, so we have what? Brain and its coverings, right? Other than bone. So we have brain. So brain is intracerebral. Then other than that, coverings. So coverings are brain is what? Many meninges. So there is a pia mater, there is a what? Arachnoid, subarachnoid. Then there is a arachnoid matter, and there is a dura. Okay. So dura, subarachnoid, and also pia mater. So usually extradural, this one will be outside the dura. Subdural is below the or inside the dura. Then arachnoid, subarachnoid will be inside the subarachnoid, and pia is almost completely attached to the brain. So almost we won't be seeing any other structure. So it is almost attached to the brain. So like just like a epithelium. So other than that, so interaxial bleed. Okay. So this is what is called as, you can see here, convex shape. Okay. Usually in a trauma patient, when there is a EDH, okay, so we have this some swelling over there. So on the external part here, okay, there will be some certain signs based on the Coop and counter Coop mechanism. Usually we will find some lesions over the scalp as well, swelling or some bony fracture, because the force will be transmitted from the external to internal. So there are no. So you can see the bleed on the outside usually on the trauma patients. So here you can see some biconvex this one structure. It's looking like a idli. Okay, so idli shape or lens shape. Okay, so this is what is called as EDH. You can see this is having a attenuation, high attenuation. So this is a normal part. If you can see here, this is a normal part here. Here you can see EDH. Okay, there is a hyperdense lesion, biconvex or lens shaped, on which side? Left side. Okay, near the temporal part. Okay, so this is, you can see here, and it is also respecting the sutures. Okay, so it will respect the sutures. It won't cross the line. It won't cross the Lakshman Rekha. So EDH will respect that Lakshman Rekha. So that is the thing with EDH. And you can see here, some patients, there is already break in the continuity of the bone on the right side. Okay, so, and also you can see there is a biconvex or a lens shaped. And usually if there is a hyperdense lesion, homogeneous, so it is suggestive of what? A clotted blood usually. But if there is an active bleeding, usually extradural hemorrhage will cause meningeal arterial tear. So it will continuously expand, and also there can be lucid interval, and patient can easily deteriorate, and these patients will have good prognosis if at all, if you are managing properly. So in this patient, you can see there is a swirl sign, that there is a hypodensity inside the hyperdense lesion. Okay, so this is a swirl sign. It suggests of active bleeding. Okay, and also now you can see here, like there are some artifacts here. Okay, so artifacts are some errors in our in the image acquisition. So so artifacts can happen when, so artifacts can be a motion artifact. These are the errors. Okay, so you can see here. So the artifacts is like just as a feature in the image, when we have a blurring of the image. So that's just an error, right? So if we are not, like, if the patient is moving, so that is the one thing. So motion artifact is one thing, and there is a beam hardening effect or streak artifact where dark streaks can be seen. Okay, and there is a partial voluming artifact as well. So where usually when you're seeing this one, right? Okay, so this one is, you can see here, usually there is a slice thickness as well for each section. So for each CT scan, there is a HRCT, high resolution. So we are increasing the resolution based on the slice thickness. If the slice thickness is 1 mm, so it will be having a higher resolution when compared to 5 mm or 6 mm. Okay, so because it is cutting the body into thin slices, so the resolution will improve, but the radiation dose will increase in those scans. So that is one thing. And so when you're seeing this, part, Okay, when you're seeing this image, so this is an average of some pixels. So we call it as voxel, not pixel. So this is called as voxel. Okay, so it is an average. So each image is made by, say, this. Like we call pixel. You have seen the pixelated images, right? When we zoom in, if I zoom here, okay, if I zoom in, you can see the pixelation part of it. Okay, the image is pixelated, right? So this we call as like voxel. Okay, so this is a we call it as voxel. Okay, so this is an average of the, all these tissues. If I see this part, so this is looking like white or black based on the, averaging of this one. So averaging of the structures beneath it. Okay, so that is one thing. Okay, so this is beam auditing partial volume artifacts. Okay, so we should also like we should be aware of this one, because this is important, because we might be confused with the, any pathology. So that's why we need to make sure this is an artifact. So we should differentiate that. Okay, so this is the EDH part. Okay, and how do we estimate blood volume? So there is a validated study here, formula as well. So this is an easy one. So like for a volume is what? Three-dimensional part of like any bleed. Okay, so like volume is a three-dimensional one, right? So we look at length, breadth, and height. So similarly here we look at the maximum length part, and we take a perpendicular. We will take the maximum length, then we will draw a perpendicular to that part, and where there is a maximum width. And then after that, this is the horizontal part. X and Y axis is completed. Now for the Z part, we need to calculate the number of, slices. So with number of slices available, like that can be visualized, the bleed can be visualized. Then we will multiply it by with slice thickness. Okay, so then it will give some value. So based on that value, we'll multiply that and we divide it by 2. So this is the hematoma value, A, B, C by 2. So this is the formula which we use for calculating the volume. So this is a rough estimate. You can use that. And so EDH, it has got good prognosis. If at all managed, if the patient is like arriving in emergency, and also diagnosis is done like early on, so it has good prognosis. Okay, when we are aggressively managing that patient. So if the emergency evacuation is required in certain patient, not in small EDH or minimal EDH, when there is a focal signs of or symptoms attributable to acute EDH, like a patient is altered, or the GCS is low or fall in GCS, and the like when there is a large hematoma volume, and if it is, there is increased like there is a mass effect. You can see here there is a mass effect. This part is compressing this, you're pushing the brain to the other side, and you can say this is the midpoint. I will tell you regarding the midline shift as well. Okay, so usually we consider 5 mm of midline shift as cutoff. Okay, this one. Okay, so this is the EDH part, and we should also look for like hematoma volume is less than this one and midline shift of this. Then we will go with conservative as well. So based on the patients, and continuously serial, serial imaging will be done in those patients. Okay, and we look for midline shift, and there are other terms known as effacement and also enlargement. Okay, ventricles, and this one we'll discuss later on. Okay, the next part, that is extra axial hemorrhage, is the, you can see this part. What is this? It is semicircular or like a moon, like semicircular or like a crescentic shape. Okay, so this is on left side. Okay, and it is what? Hyperdense and just inside the brain. Okay, so this is on left side. So this is what? Subdural hemorrhage, and it does not respect Lakshman Rekha or the sutures. So it will cross that. Okay, so it will cross it. Okay, and then after that, it is almost occupying the entire part. So there is a frontotempoparietal, almost occipital, till that it is reaching. So there is a large SDH. Okay, and it can cause mass effect as well. And the usual, the usual cause of this bleeding will be the venous one. Okay, so here you can see when there is a bleeding, usually effacement is. Usually you are seeing here the gyri sulci. So this is the normal cortex. So this will be properly visualized. If we are unable to differentiate between the gyri and sulci, if they are almost clubbed together, so usually we call it as effacement of sulci. Similarly, we also look at thin slit-like ventricles as well. Okay, so this is SDH part. Okay, so this is the SDH, and also it will also cause mass effect. Here you can see this is the midline part. So we should look at the symmetry as well. So if it is not symmetrical, so then it can cause what? like mass effect, then it will push the the brain to the other side, and there can be herniation as well. Okay. So this is the so an acute subdural hemorrhage will show hyperdense, and if it is as like as time passes, then there can be normal degradation of the blood products, because of which there can be isodense, and there can be acute on acute on chronic stage as well in certain patients. So if there is a dilated pupil or any fall in GCS, and if the clot thickness is more than, clot thickness is the horizontal dimension, volume is a three-dimensional one. Okay, so this is the 2D part, and that is the 3D part. And usually when there is a midline shift of the fallen GCS, mainly clinically and other like any criteria will encompass clinical, imaging, and other things. So clinically, if the patient falls, or if they deteriorates, or if the imaging part also, so if it is showing an increase in this one, so we'll go ahead with the emergency evacuation. Okay, so that is one thing. Okay, now okay. So now coming to the other space, other important space. Okay. So now you can see, I'll show you one thing. Okay. So you can see here. So this is the topmost part. You can see this, right? This CT part, right? Anyone please?
Yes, yes, sir. We can see.
Okay. You can see this. Okay. So this is the topmost part. Okay. This is the topmost part. I'm scrolling down. Okay. Now you can see this one. Here is the high frontal, and here is the high parietal. Okay, this is the high parietal here. Okay, I'll do the scrolling again down. I'll scroll down. Okay, now you can see this. Okay, so there is some sulci here like a mustache. Okay, just anterior to that, here you can see this is a omega shaped. Okay, so this is the central sulcus, and this is the precentral gyrus will be what? Sensory or motor? Precentral gyrus will be what? Sensory or motor?
Sensory.
Sensory. Okay. Post central.
Motor.
Okay. Okay. So pre-central and post-central. Based on this, we look at what all these things. Okay. Gyri sulci differentiation and effacement as well. Okay. So this is the mustache and also like marginal sulcus. Okay. Then after that, we'll just scroll down. Okay. So this is the high frontal, and this part is the high. 1 minute. I'll just draw on this one so that you can see. Okay. So this part is the high frontal, and this part is the high parietal. Okay. 1 minute. Okay. Now we'll scroll down again. Okay. Now you can see this. Okay. Now while I'll scroll down, I'll look at, there are some spaces. These are gyri sulci differentiation is there. Now you can see there is some black color stuff here coming out. Okay. This is what? Sylvian fissure. Okay. So this is the Sylvian fissure. Now you can see this is the front end. This is the anterior one, right? Anterior portion, anterior part. This is the posterior part, the posterior one. So here you can see something coming over here. So this is the Sylvian. Bilateral, you can see here, Sylvian fissure is coming here, and you can see something filling in. That is the black color one. So that is a, it is filled with what? CSF, obviously. So this is the Sylvian fissure. And just once we get the Sylvian fissure, it means what? It denotes the separation of frontal, and this is the temporal. Now the temporal lobe starts here. Okay. And I'll scroll down. Now you can see some other structures here. Okay. Some other spaces, the black color spaces. Okay. Inside this. Okay. So normal CSF, like what is the function of CSF? It is produced by, choroid plexus in the ventricles. Then after that, there are, it will flow through the ventricles, the other ventricle, lateral, then third, then, fourth, then it will go through the, foramen of Magellan and this one into this, it will float in the subarachnoid spaces. Okay. So these are all the subarachnoid spaces. So this black color is suggestive of CSF. Okay. So this attenuation will be what? Around 8. Okay. So now it is looking black color. Okay. It is not jet black. Okay. It is looking black, but it is not jet black. So, so this is filled with fluid. That is CSF. Okay. Now this is the, you can see the temporal bone, temporal lobe. Okay. Here. Now, if I scroll down, you can see other structure here. Okay. So this is the medial part of temporal lobe. Okay. This is the medial. Okay. So this is the 1 minute. Okay, this you can see this one, right? So this is the medial portion of the temporal lobe. So this we call as uncus. Okay, so uncus. So this is the uncal part. Okay, so this is important to identify because we usually use the terms uncal herniation. So this is even though this is an axial section, we need to identify uncal herniation even in an axial section as well. So that's why I'm telling you. So this is the uncal, this one. Okay, and uncal part. Okay, uncus means like to hook actually, and this part is important. So if the patient comes with a seizure and we all ask for aura in patients with seizure, this is to localize the onset of seizure activity. So all the electrical this one, so disarray. So usually we like ask for this aura. If the patient complains of olfactory or any gustatory sensations prior to seizure, so that is suggested usually uncinate seizure. Like the focus is from the uncus. Okay, so uncus is means to hook up, like hook. Okay, uncus means hook. So this is the uncal part, that is the temporal lobe, medial part of the temporal lobe. Okay, now I'll give you another mental model here. Okay, so to remember the subarachnoid hemorrhage and also this one. So okay, okay, Arushi. So what does this structure look like? Any cartoon you can remember, Arushi? This part? Arushi,
Uh, yes, sir. Yes, sir.
yes, this part. What does it look like? Any cartoon? This part. Can you see this?
Yes, sir.
Okay. Okay. You did not watch this one, Cartoon Network or other Pogo. Okay.
Pokemon.
So, Pokemon.
It looks like Mickey Mouse. I don't know.
Yes, Mickey Mouse, yes. So this is a Mickey Mouse. Okay, M for M. Okay, this is a Mickey Mouse, not Pokemon. Okay, so this is a Mickey Mouse. So Mickey Mouse, M for M, that is M for midbrain, M for Mickey Mouse. Okay, so this is a midbrain part of like this one. So once you get this part, okay, you can see this, like usually like you can see this part, right? So Mickey Mouse, here you can get that. Okay, so Mickey Mouse is smiling. Okay, Mickey Mouse is smiling, and Mickey Mouse is in ambient environment. Okay, so Mickey Mouse smile is black color. You can see this smile, right? You can see my cursor right here. Yes, can you see my cursor here while I'm
Yes,
doing
sir,
that?
yes.
Okay, so this is the Mickey Mouse smile here. It is black color. Okay, and it is smiling. So and Mickey Mouse is in ambient environment. Okay, so Mickey Mouse is in ambient environment, and it is looking at a star. Okay, it is looking at a star. Usually stars are bright white color usually, but our star is black color. So this is our star here. You can see the star here. This is our star here, large star. Usually this is the cow, circle of Willis, where the circle of Willis is will also be present. So this is the our star here, black color star. Okay, so the black star is black. Mickey Mouse is smiling, and it is in a environment black, in a ambient environment. Okay, so ambient. So there are some cisterns, and so in subarachnoid spaces, we have a sylvian fissure with a sylvian cistern here. Then we have some here like the perimesencephalic, that is the midbrain. Around the midbrain, we have some this one. So here we have the interpeduncular cistern. This is the interpeduncular cistern here. Then we have perimesencephalic, like the Mickey Mouse has got midbrain, has got what? There are some four this one. What are quadrigeminal? Quadri means what? Quadri means four. Okay, so we have superior and inferior colliculi. Okay, we have a quadrigeminal cistern here above that. Okay, then we have ambient like ambient cistern. Okay, and we have the star is the supracellular cistern here. You can see the star right here. This is the star here. So this is the star is supracellular cistern. Okay, now if you can see all the sulci, gyri sulci, usually you can see this part, right? So this one, if they are black, that is a good thing. Okay, and if the Mickey Mouse is smiling and the smile of the Mickey Mouse is black, that is a good thing. If the the star is visible and if it is black, that is also a good thing. Okay, anything, if the star becomes white, if the Mickey Mouse smiles white, if the smiley of the Mickey Mouse is white, that is suggestive of SH. Okay, and if the or the guy, all the sulci, if it is filled with white color structure or hyperdense, that is suggestive of SAH. Okay, sulcal SAH. We call it a sulcal SAH or some tentorial SAH, or we can call this some other basal, like based on the location, we call it interpeduncular SAH based on that. Okay, so that is one thing. So if the star is black, that is a good thing. If star is white, that is a suggestive of there can be interhemispheric as well, interhemispheric hyperdense lesion as well. So based on the various location, they can be this one. Okay, so SH. So if the star is white, that is a bad thing. Similarly, we have what here? Like there is Ancus. Okay, so usually we have multiple, okay, herniation as well. So when there is a mass effect in extraaxial or also intraaxial, so usually we have what? Subfalcine herniation. So this is the midpoint here. Okay, so this is our midpoint here. Sorry. So this part is from falx cerebri. Usually we draw a straight line here. Usually, so this is the midline here, and we compare here with the septum pellucidum in the midline. Okay, so if there is a mass effect, it will move. So there can be a midline shift. Okay, so because of which there can be there can be sideward movement or lateral movement of the septum pellucidum. So based on this, we'll draw a line and we'll compare if the septum pellucidum is here. Okay, I'll just draw a line and compare and also count the this one distance. Okay, so so if the distance is more than 10 mm, so I'll write it as 10 mm. Okay, that is suggestive of this one. So the septum pellucidum, the midpoint that is separating the these two structures, lateral ventricles, that is the septum pellucidum. So that we compare it with the midline of the skull. So that is how we check for the subfalcine herniation. Okay, so that is one thing. So and midline shift as well. So here we need to look at, we have a ventricle as well here. So lateral ventricles are available and there are multiple frontal and occipital part as well. Similarly, there can be what? There can be uncal herniation. So once we scroll down, so here you can see the uncus. Okay, if the star, one part of the star is not visible, okay, this part is almost obscured. Okay, that means uncus is almost pushed towards the is pushing the the suprasellar cistern. Okay, so that part will be pushed and this one will be collapsed almost. You can't see this part. Okay, only the other side, the right part will be visible and left side part won't be visible if there is a left side uncal herniation. If it is completely collapsed, if you are unable to see any part of this one or like any part of like if you can't appreciate a suprasellar cistern, then it is suggestive of bilateral uncal herniation. And if you can't see the smile of the Mickey Mouse, or if it is not even visible, it means what? It is at what location? Near the tentorium. Okay, so tentorium location can be, tentorium can have a what? Cerebrum. There is a cerebrum above that and a cerebellum below it. Okay, so transtentorial herniation can be ascending, where cerebellum will go above and because of mass effect, or cerebrum can come down. That is a descending transtentorial herniation. So there can be descending transtentorial herniation or ascending transtentorial herniation, where you can't appreciate these sulci, these spaces. Okay, this perimesencephalic spaces will be completely occluded. Okay, so in that part, so that is suggestive of transtentorial herniation. Similarly, once we scroll down, okay, so this part is the foramen magnum. Okay, so this is the foramen magnum here, where usually we have a occipital bone is there. So once we get that this one, so brainstem is there is a continuation of spinal cord. So this should be almost there should be some space, black color space that should be appreciated around this part, because the spinal cord, everything should be like freely floating inside this structures. So if it is crowded, if there is a hyperdense lesion and it is completely crowded, it is suggestive of central herniation, okay, or tonsillar herniation. Okay, so this is this can be appreciated in this part. Okay, so other than these internal herniation, if the patient has any surgery or any this one, so usually there can be transcalvarial as well. Okay, where usually through the skull there can be a protrusion of brain as well. Okay, so you have understood, right? Like this one. So there is a Mickey Mouse here that is suggestive of a midbrain, and it is looking star. If the star is white, that is abnormal. If the smile is white, that is abnormal. If these two are not visible, that is also abnormal. And similarly, these Sylvian systems should also be black color. Okay. So that is how we need to see. Okay. So there should be a smile, and also there should be, and it should be black color. Okay. So that is the SH part. Okay. So this is, you can see here, this is a star. Okay. And if at all, if we have any like white color in a non-trauma patient, so we should suspect what? Any spontaneous subarachnoid hemorrhage. Okay, subarachnoid hemorrhage. So we need to look for any aneurysmal bleed. Okay, in aneurysmal spontaneous bleed, non-traumatic, usually there is a like role of what? Clipping and coiling, because it is not due to some this one, like if it not due to trauma. So usually we'll go ahead with CT angio to confirm that. And if there are some multiple patients, like in the previous shift as well, so there are patients with similar this one. So CT angio was positive, which is suggestive of like any like aneurysms in red area recently. So you can see this blood in the cistern here. So, and also it is covering here. And so this is the suprasellar cistern with completely the blood. There is SH over there. Okay. And similarly, there can be blood inside the ventricle as well. Okay. So when there is a hyperdense lesion, as you can see this part, this is suggestive of left side sulcal SH. Okay. So sulci, fissures, ventricles, and cisterns. Okay. So, and also after that, blood can accumulate where? So extra axial is done. Then after that, we'll come to intraaxial. Okay. So intraaxial, because of a spontaneous bleeding in a hypertensive bleed, so there can be what? Deep, usually we see at some internal location or deep nuclei, usually in putamen or other basal ganglia regions. Okay, if there is a trauma, usually we'll have a intracerebral bleed. We call it as hemorrhagic contusions. Okay, multiple hemorrhagic contusions. And when there is a hemorrhage, it will obviously it is almost like an inflammation, like there is a trauma, because there can be leaky capillaries, so there can be ooze as well. So there can be like other edema and other features as well that can be appreciated around the. Okay, so there is a bleed, and also there is a mass effect, and there is a hypoechoic lesion, hypodense lesion around the okay, so that is one thing. Okay, so like I'm just summarizing this part, Gyri, sulci, and also Sylvian fissure, you can see that. So there was a recent, I would like to share one incident, which that was my anchoring bias. I would like to share my anchoring bias. There was a patient, middle-aged, like a female patient, came with complaints of only aphasia. Okay, so like aphasia, and she was completely normal. Other than aphasia, like it was a Broca's type part. So like in that patient, first of all, I thought, obviously, because of patient was completely normal, no hypertension, no comorbidity, sudden onset of this one. It was almost 1-2 days, prior to this one. So patient came 1-2 days after the incident. So once patient came to triage, so I told the JR over there, okay, like this might be malingering, I'm not completely sure. Okay, let us again evaluate. So, even though I was having a anchoring bias, I was not sure. So in that patient, after workup, patient had a interhemispheric SH, and then after that she underwent a MRI, which is suggestive of some lesion. Okay, so like these patients can be, like we have. Like we need to rule out when we have a malingering this one diagnosis. We should not completely base our diagnosis on our initial instinct or gestalt. Okay, even though we have experience, like after that, like I was like obviously wrong. My opinion was wrong, obviously. So I have to change that. And also I've learned a lot from like there can be a SH and other things as well. Broca's aphasia, like not because of interhemispheric this one, but the patient was having some other lesion as well. Okay, other than this one. Okay, so the patient can present with just a symptom of aphasia and can have a SH as well. Okay, that patient had interhemispheric SH and with other lesions on the lateral, frontal and other things. Okay, so that is one thing like you should be appreciating. Okay, okay, so this is a lateral ventricle. So CSF, our brain is how much? It is of around 1.5 kg, and it is floating in the CSF. It is almost like floating in the CSF, and the effective weight, we are not feeling our head weight, right? So we are not feeling the head weight because it is floating in the CSF. The almost 1.5 kilo is almost there is a 90% decrease in the weight, almost effective weight that we can appreciate. So like it is almost it comes down to 150 grams. Okay, so in CSF it is almost floating. Okay, so if at all if there is any bleed, or if there is an obstruction, or if there is any leakage of CSF or any other injuries, so brain can herniate because it can't because of gravity and other things. Usually there can be herniation easily. Okay, and mass effect. Okay, so these are the lateral ventricles, and lateral ventricles combine, like they open into. Then we have the basal cisterns. Okay, so we have suprasellar, perimesencephalic, prepontine, and cisterna magna. Okay, so perimesencephalic is our the Mickey Mouse part. Suprasellar is the star part. Prepontine is interpeduncular and other part, and cisterna magna is the big one, so large one. Okay, so you can see here interpeduncular, and this is the ambient. Quadrigeminal is the superior colliculi, inferior colliculi. So around that part is the quadrigeminal cistern, and you have suprasellar cistern as well here. Okay, and near the cerebellar pontine angle, and before this is the prepontine angle, and this is the fourth ventricle here. Okay, and then after that, then we have something called as like hydrocephalus. Okay, so ventricle can also dilate, right? So ventricle. So when can ventricle dilate? Usually we see in hydrocephalus. Hydrocephalus is seen in some patients, elderly patients, where they have a cerebral atrophy, because of which there is a exvacuation. Because of decrease in cerebral space, the ventricle will usually expands. Okay, that occupies that space, and there can be periventricular ooze as well in certain patients as well. Okay, so this you can appreciate here, ventricle and lateral part, and also the temporal horns of the ventricles are also increased in these patients. Okay, so in atrophy, what will happen? Sulci will be enlarged, ventricles will be enlarged, cisterns will be enlarged. So atrophy will cause all. Okay, A for A, sulci, ventricles, cisterns, all will be enlarged in atrophy of brain. In hydrocephalus, usually only the ventricles will be enlarged, and the sulcus or sulci will be effaced. Effaced means it will almost the gyri sulci will be almost could not be differentiated, like usually won't be differentiated properly, and cisterns will also be small, they become small. Okay, and in cerebral edema, the sulci, ventricles, and also cisterns will be effaced. All of these three will be completely effaced in these patients. So this one is what you can appreciate a ventricle here. Okay, can you see this part, right? I'll just zoom in. Okay, so you can see here, you can appreciate the ventricles here, and you can appreciate the sulcus, sulci, multiple sulci, gyri sulci differentiation can be done. It is not complete. So this is what? Is it normal? Okay, so we'll see. Okay, then after that, what is this? You can see here, there is a ventricle, sulci are enlarged, ventricles are enlarged, and you can also see, the cisterns are also enlarged. Okay, so it could be some diagnosis. We'll look at the diagnosis. Okay, now here we have ventricles enlarged, but we can't appreciate the sulci here. Okay, in the third part. Okay, and can you appreciate this one? Cisterns? Anyone? Okay, so what is this? And finally, this part. Okay, where all of these three, all the sulci different. So these three are, can you appreciate anything here? So the ventricles are almost like a slit-like. You can't appreciate the sulci gyri, and also cisterns are also almost closed. You can see here, almost it is closed. You can see this part, the Mickey Mouse smile is almost lost here. Okay, there can be diffuse cerebral edema, because of which it is completely obscured. Okay, so when there is bilaterally diffuse, it will be difficult for us to comment so on that part as well. Okay, so this one is what? So this is it normal? So this is a normal one. So in this three of, all the three, sulci, ventricles, and also cisterns are enlarged. Here we have only this ventricles enlarged, and some part of it, the sulci will be effaced, and some part, see, there can be, based on the, hydrocephalus, this one location, based on that, there can be some appreciation of some part can be enlarged. Okay, in edema, all, ventricles and also sulci will be this one effaced. Okay, so you have understood, right? So this hydrocephalus, we have only sulci effaced, and ventricle solubilized and cisterns are also effaced. Okay. Okay, then after that we have brain. Okay, so in brain, B for brain. So any blood can be very bad. A for airway, or air spaces, mainly nasal, paranasal. Then we have completed blood part, that is extraxial, intraxial. Then we came to blood can be very bad. Any blood can be very bad. Okay, so C and V, cisterns and ventricles, we have completed. Then after that, bad, or like one part is brain. Okay, B is the brain. Okay, so in B there can be space occupying lesion, there can be vasogenic edema, there can be abscess, or we usually use what, CT for what, stroke as well, and also other trauma. In all trauma, with a patient with a like who meets the criteria of for CT head, usually we go ahead with that, and cerebral edema and bleeding and other things as well. Okay, so in cerebral edema, as you have seen, sulci, ventricles, and also cisterns are entirely effaced. Okay, then so loss of CSFs containing spaces, sulci effacement, ventricle space, and also cistern. These are all spaces. Okay, these are not potential spaces; they are spaces. EDH, extradural space, is a potential space. If you tear a meningeal artery, then there can be bleeding as well. Okay, so and there can be, because of diffuse like there can be, because of cerebral edema, there can be gray white differentiation, loss of gray white differentiation, and increased ICP. So on focus we can see appreciate increased ONSD, optic nerve sheath diameter. Okay, that is also, and can also be appreciated. Okay, and there can be transfalcine herniation, or and also other herniation as well. Okay, then there are certain things called as, like there is a diagnosis pathology called as diffuse axonal injury, where because of shearing force there can be multiple dot like contusions that can be appreciated in CT, and it is not that sensitive. Usually we go ahead with the MRI. Okay, so, and other than that, what are the other things we look at in CT? Can you see this part here? Can you see this? Anyone? Mehul?
Sir.
Can you see this one here? Like I'm opening. Can you see my screen now?
Which one, sir? I'm seeing you scrolling down.
Yeah. That is that is okay.
Okay.
So okay, 1 minute. Okay. Okay. So there are in SH as well, we should remember about the Hunt and Hess scale and modified Fisher scoring. Okay. So Hunt and Hess scale is a clinical grading scale, and also modified Fisher is a CT one. Okay. So this is a clinical one and this is a imaging part. Okay. Based on the various this one, so we grade. Once we get any diagnosis, we always stratify, because our interventions are based on our stratification. If there is a fever, you will tell mild, moderate, severe, all with associated with Sills or Riger, high grade, low grade, or based on, you will stratify always, because you have lot of instruments, or you have a lot of astras or shastras. Okay, you have to use only certain part of your instruments, or equipments. You will give IV in certain, you will give oral in certain. So based on this, you'll always stratify in any this. Once we have SH diagnosis, will stratify it. Okay, based on Hunt and Hess, that is a clinical one. If the patient is high, like if almost comatose, we'll call it as grade 5. And if the patient is having a high grade or IVH, in intraventricular hemorrhage, we almost tell it as a grade 5 modified fissure as well, grade 4, grade 5. Okay, so that is one thing. And similarly, for a stroke patient, Mehul, like till what time do we have? Like, because we also have, I'm just rushing in because we also have a CTC span, that's why.
Sir, maybe we can do C-spine another day, and we'll just continue with whatever is there in the CT head.
Okay. Do you want me to continue only CT head now? Because it's almost 1 hour now. That's why I'm.
I think we can continue complete
So only
CT
CT head. CT head. Okay.
CT head.
Okay, later on we'll do complete the CT space. Again, we have a different this one, right? Because it will take some time.
Sir.
Okay.
Sir.
Okay. Now you can see this part, right? Okay, so this imaging usually, why do we do imaging in a CT with a stroke? Usually it is for diagnosis, prognosis, and also treatment selection, right? So we do CT head. So for diagnosis, whether it is a stroke or not, whether it is ischemic or hemorrhagic. Okay, and also based on this, we have what prognosis as well. Okay, what is the size? So like there are some 1/3 like middle cerebral rule, and also aspect score. Usually we use NHS score is what? Clinical one, to categorize or stratify the stroke into like mild, moderate, severe, or the based on that. So based on the scoring, we stratify the score. Acute ischemic stroke. Again, based on the imaging also, we can stratify the stroke. Okay, that is the aspect score, where we use like ganglionic and also supraganglionic. Okay, so here you can see here, this is the this is what lateral ventricle. Here we have what lateral ventricle draining into third ventricle. Here this is the foramen of Monroe. Okay, now again, then after that it will go into the fourth ventricle here. Okay, so at this point you can see this part is the caudate nucleus. Here you can't appreciate it properly, and once we get this part, can you appreciate it? Can you appreciate the grayness? I can't appreciate it on my screen, but not sure.
We can see a little bit, sir.
Little bit, na? Okay. So here we have internal capsule here. Okay. And we have something over here. Okay. Lentiform nucleus. Okay. Globus pallidus, lentiform nucleus, other things. So this is a basal ganglia. So we have a cortex. We have a subcortex. Okay. That is subcortical region where we have nuclei. So gray matter is mainly what? That is mainly gray matter is nuclei. Okay. All the, heads of the axon or this part. Okay. So carrion part, the nuclei part. Similarly, we have a basal nuclei or the basal ganglia, we call it as. So that is the ganglionic level, and also supraganglionic level. We divide the, stroke. Stroke will look like hypodense lesion, usually evolved stroke. And other than that, if the patient has a hyperdense, like if the blood is almost clotted in this one, if it is early on, usually we see at vascularity as well. It can be appreciated even on a NCCT as well. So in a non-contrast, this one, usually we use it. We can appreciate, MCL, dense MCA sign, that we call it as. So usually we can appreciate it over here usually in this one. Okay, in these sections. So that is one early sign. And loss of gray-white differentiation, that is also an early sign of stroke. Okay, and similarly we divide it into we divide the aspect score we have at ganglia level and also supraganglion level, where the cortices are divided into M1, M2, M3, and the score is almost till 10. Okay, 10 is a good, 8 to 10 is good, and we will stratify it. Okay, so we diagnose, we use CT for diagnosis, then prognosis. For prognosis, we use aspects and other things. Okay, and also look for whether it is ischemic or not, and treatment selection. And see, actually, stroke is altogether a different section. I'll cover it later on. This one, I have this like I have the slides and other things as well, but it requires a complete lecture for that. Okay, I'm not covering stroke completely because we use CT angio as well, based on whether there is any large occlusion or not, large vessel occlusion. Okay, so 4 things you need to remember in acute stroke imaging are: the mental model which I have given for bleeding or any intracerebral bleed is blood can be very bad. Okay, I will cover the bone part as well, but I'm just covering the parenchyma part of the non-trauma as well in this. Okay, so the 4 P's which we look at in acute stroke in this one will be parenchyma. Okay, assess early sign of acute stroke, rule out hemorrhage. Okay, in unenhanced cut, that is the enhanced NCT. Then we look at pipes. Okay, P for parenchyma, first is P. Then second P is pipes. That is, we look at vessels. Okay, carotid and this one. Then intracranial circulation as well for any intravascular thrombus. Then we look at perfusion. That is the CT perfusion imaging. CT, this one. Okay, look at the perfusion as well, where we have various terms. That is the cerebral blood volume, cerebral blood flow, and mean transit time. Which way, again, it has to, like, this is another lecture as altogether. Okay, then we have a penumbra. We look at core, then also penumbra. Penumbra is at risk for again infarction. Okay, so usually if there is a core, based on core and this one penumbra mismatch on this one, there are multiple dawn and diffuse trial. Based on that, we usually have this. We'll select the patients appropriately for giving thrombolysis based on if the patient is out of window, like more than 6 hours or a wake stroke. So based on that, we go ahead. Okay, so that is one thing. And the on NCCT, you look at, this is an NCT part. So that's why we look at in a stroke patient any cerebral, intraventricular, subarachnoid, subdural, extradural hemorrhages. Then we also can appreciate, eye deviation. You can see here, there is eye. Okay, you can see this part, right? So here you have lens. It is almost the patient is looking at, the like biconjugate. So the two eyes are in a conjugate motion. Okay, they are symmetrical and they are looking at like in a straight line. So it is not deviated usually. And also if there is eye deviation or gaze fixation towards that, that can be appreciated in CT as well. Okay, eye deviation can be appreciated. Then hyperdense artery sign. Not just MCA, you can also appreciate the basal artery as well, other arteries as well in on NCCT. Okay. Then early ischemic signs are obscuration of the lentiform nucleus. So any loss of differentiation of gray white usually, even though nucleus is means what, it is always will have a like the gray, like it will be somewhat hyperdense when compared to the surrounding this one. Okay, white matter. Okay, so lentiform nucleus, when there is obscuration of that, when there is loss of insular ribbon sign, that is on the lateral part of the temporal lobe, and loss of gray white differentiation of surface cortex, that is all suggestive of stroke. Okay, stroke is because of obviously vascularity. We have to go through that imaging as well. Okay, so then we have a aspect score. So this is an image like stratification of the stroke on imaging CT head. Okay, so that is one thing. These are the signs of usually on NCCT that can be appreciated. Hypodense lesion that can be appreciated, and sometimes there can be hypodense lesions that can be, we can mistake it with the other things as well. There can be gliosis as well. So where there can be like old infarcts, because glial cells are what, astrocytes are just like a supporting cells of brain. So if at all there is a gliosis, it can also show hypodense lesions. Okay, then other than that, the non-trauma part of intraparenchymal bleed. Okay, so if the patient elderly adult with hypertension with hemorrhage and basal ganglia, it's almost so basal ganglia, cerebellum or thalamus. So these are the structures where usually there can be like these are prone for hypertensive bleeds usually, and multiple basal ganglia microbleeds on T2 of MRI, and prior lacuna and periventricular diseases. So this one can be in these patients we should suspect what, hypertensive bleed. And if it is not pertaining to these structures, the deep structures, if it is pertaining to a lobar, if it is a larger one. Okay, so it is suggestive of an amyloid angiopathy. In an older patient presenting with elderly patient presenting with this one, we need to suspect hypertensive hemorrhage or amyloid angiopathy in terms of lobar or cortical hemorrhages. Okay, and if at all, if we have any extensive subarachnoid or aneurysmal adjacent to hematoma, there can be malformations. Okay, so vascular malformation can be aneurysmal AV malformations or developmental anomaly, AV fistulas and other things, where we have hemorrhage adjacent to some vascular structure. Okay, in these patients we go ahead with the CT angio, look at the vascular structure, then like based on this one we come to a diagnosis. So so there can be arterial or venous. So venous this one, so cavernous malformation or AV malformation, there can be this one. And similarly there can be a space occupying lesion. Okay, so when there is a more edema that can be than expected, and more heterogeneous signal than expected, multiple enhancing lesion, then hemorrhagic neoplasm can be this one appreciated. Then clinical history of infarct with history of thrombolysis, then you went with a serial imaging which showed a worsening of this one. So that is suggestive of hemorrhagic infarct. And similarly, we have a like other than that like vasculitis as well, and moyo disease. Okay, so these are the things you need to remember. Okay, the last part of our this one discussion will be the bone part. Okay, so we'll come to the bad part. Okay, so bad is bone. Okay, so here we look at what, symmetry. Always body loves symmetry. Okay, so if symmetry is lost, we need to suspect some pathology. Okay, so if there are skull fracture, we need to compare with the other part. Okay, other right or left. Okay, so if it is smooth, not ragged, and also if there is no ragged margins, and also there is no increase in the width of the fracture line, usually we won't suspect anything. If it is discontinuous, or if there is any so based on that we'll appreciate a bone and also differentiate a normal suture from a fracture. Okay, so skull fracture and suture, so we'll come we'll compare it with that. Okay, so you need to identify the usual pattern of the lambdoid suture as well to appreciate a fracture. Okay, and so this comes with the practice. So multiple times, even though I'm imparting knowledge on you, you need to go through. So there are a lot of free resources that are available on just a Google search. So you can just you have to scroll through multiple pathologies. Now you have to first of all accustom your eyes and also learn visual pattern of the normal CT. So then after that you can appreciate this one. Okay. So based on that, and also in bone window, when there is a bone fracture, there can be, you can see. Hello.
हाँ सर, अभी आपका we can see you.
So you can't appreciate, you can't see my screen. Okay, wait. कहाँ तक नहीं दिखा है वो वाला?
We are talking about the fractures.
Bone है ना, bone है ना. Okay.
Bone.
Okay,
Yeah.
okay.
You were audible still the last 10 seconds ago. Wow.
हाँ, अच्छा. Okay. ठीक है. So bone में usually we look at what? Cortical, this one. Okay. Cortical, like loss of continuity of cortex. Okay. So based on that, we can appreciate. And if at all, if it is near the, air spaces, usually we can also appreciate hemosinus as well. Okay. In this one also based on the, depression. So when there is open of, like when there is direct communication of intracranium to the extra, like environment, usually we have to operate that. And also 5 mm of depressed skull fracture, open communicated, these should be operated in these patients. Okay. And there can be adjacent bleeding as well, or air. Okay. So that's all for today. Like I like there are like I've given mental model, and I hope I've done some part of imparted some knowledge. Okay. If you have any doubts or any queries, you can ask me. Anyone?
Sir, when you are calculating that volume, no, ABC by 2 score, C part
Yes.
is number of slices, no?
Slices into thickness of it.
Okay. So number of slices, the blood is visible.
Can be visible, yes. Number of slide that, like, because thickness is also a 3-dimensional part, right? So that's what we go. Like we'll count the number of it. Okay. How to describe the area of blood as in frontal and temporal? Same, like area of blood means like we bleed. Okay. Like area of bleed, again we go ahead with this one only, this formula only, ABC by 2. Okay. We'll just calculate it. We have a usually in this PAX bin, you don't have
Sir, I mean,
calipers.
the location, sir. Where? How do we define the location?
How do you define? Okay, location. Okay, location is like I've given you this one, right? So this is the frontal. This is the frontal part, Sylvian fissure. Anything anterior to that is the this one. And once you go above that, so that is you can see this PAX, right? So
Yes,
here
yes.
you have a high frontal. You have this is a temporal part here. Okay, so temporal, again bone also accompanying that. So based on that, you appreciate it. Okay, any bleed or any this one. Okay. Frontal is anterior to the Sylvian fissure. Okay. Then frontal bleed, then temporal part, then parietal will be above that. Okay. Above once you don't see any Sylvian fissure, you see this part, right? So here you have a parietal part here. Okay. This is the parietal part here. Then like based on that you describe. Okay. You will always see, always there are landmarks. Landmarks are what? Usually there are bony, or there are some certain structure. You call like a greater trochanterial landmark or a ASI as a landmark. Okay, for ascitic tapping, you do 2 finger breaths in medial, 2 finger breaths cephalad. Okay, similarly, landmarks for anything will be the structures won't change. So usually, the landmarks, these are the landmarks where we decide to differentiate it. Okay, frontal and parietal and this one. Okay. Any more doubts or anything? Mehul, do you want to add anything?
No, sir, it was a really good class, sir. I think you explained everything well, right from the basics.
like there is much to do like much more actually. So I've covered only basic part, and also I did not cover many like tuberculoma, meningioma, other things. I have that part as well, but it will be higher, you know? So that's why like it will be more. So first of all, you guys need to scroll through these structures, and just search for Paxbin or this one. You can also search for in Radiopedia as well. So these are available freely. And also make sure like you just adjust this one, and also go like maneuver around these terms as well. Invert, when do you invert, and also zoom in when you do this. And we have a packs, universal packs available easily. Like you can go to trauma center as well, where you can say multiple pathologies. Also appreciate a CT abdomen as well. We'll discuss later on for that, and there is something called as play clip. Okay, so the multiple things you can do here, and also you can also annotate here, measure here. Okay, so you can say okay, this part, right? So like there are multiple things we need to maneuver around these this one tools. Okay, any more questions, anyone? Do you have any doubts or queries? Arushi A Kulshrestha, who is this? Mayuri, Arushi, do you have any doubts?